So I've been tasked with talking about asymptomatic severe aortic stenosis in the first instance, and my take on this is pretty straightforward. I'm fairly conservative in my assessment of these patients and rely pretty strongly on history, but we'll go through some of the other options that we have here. I certainly see a lot more aortic stenosis since I started doing transcatheter aortic valves, and I'm also becoming quite an adept geriatrician as well, and we'll talk about those issues. So the natural history of severe AS is pretty well documented, and the main issue becomes when you're symptomatic, really, and it's kind of like falling off a cliff. When you have the triad of symptoms, including angina, syncope, and heart failure, symptoms and mortality drop off within 3 to 5 years. We'll look at some of the prognostic factors for that. The data out there is quite interesting in that it doesn't often distinguish between aortic valve replacement as opposed to mortality. They group both as endpoints, and that's somewhat difficult when you need to figure out how to manage these patients. But this graph shows there's a clear variability in progression of aortic stenosis. So there's no one size fits all, but there should be a few prognostic factors we can rely on. Certainly, what we do know is that 1/3 of patients with severe asymptomatic aortic stenosis will become symptomatic within 2 years. 2/3 will either have an aortic valve replacement or cardiac death at 5 years. But the risk of sudden cardiac death without symptoms is pretty low. It's less than 1%. And when you stacked up that against the risk of a uncomplicated aortic valve replacement being approximately 3%, it's a good reason to stand back and think carefully before pushing people towards surgery. So when you look at what are some of the potential predictors of symptom development, exercise testing is certainly useful, and I'm going to go into that in a little bit more detail. Some of the other concepts that we need to look at require a very accurate echocardiography without inter-lab variability and inter-examination variability. And my experience has been that that's not always the case, and so we have to be careful about our measurements and interpretations. That being said, the aortic valve area is certainly useful, particularly when indexed for body surface area. The peak aortic velocity is useful, and I'll talk about a little bit more. A couple of other features like the rate of progression of peak velocity, whilst there is some data to support it, I would argue that it would be quite difficult to determine that on an accurate basis. The assessment of left ventricular systolic function we know is inherently flawed in severe aortic stenosis, and many people advocate stroke volume. The issue about left ventricular hypertrophy in the absence of hypertension is important, and left ventricular mass. Valve calcification has been purported to be a determinant of progression, and certainly has been shown to be in relatively young patients. A study of about patients with an average age of 57 really looked at mild calcification versus moderate to severe, and showed that, those with moderate to severe calcification predictably deteriorated from a symptomatic perspective. They didn't die suddenly, they developed symptoms and had AVR. And that's important. From my practice in Australia, where the majority of my patients with aortic stenosis are over 70, it's unusual not to see calcification, and it's less relevant. Exercise testing, I think, is useful, and I think the first thing to emphasize is that it's safe in patients with aortic stenosis when done appropriately. And things to look for include symptoms, a fall in blood pressure, ventricular arrhythmias, and ST segment changes. Now, the protocol that you use can be the modified Norton or the modified Bruce based on what your patient can actually do. But at the end of the day, you want them to exercise in a safe capacity, and I think it's a useful way of monitoring progression. The use of exercise stress echo is complementary to that, and there's been some studies to suggest that in patients with normal stress tests, you can actually further predict progression based on certain parameters on exercise stress echo, including an increase in your gradient of over 20. And they categorize them into those with a low mean gradient as opposed to a normal mean gradient. The peak aortic jet velocity, particularly in very severe aortic stenosis, certainly is a useful way of predicting decline. It's less useful with moderate to severe. Medical therapy for asymptomatic severe aortic stenosis is an easy slide to discuss because there's not really much out there that works. There's been a lot of trials that postulated a variety of different things, but I'm not convinced that there's anything really that is useful in preventing progression in severe aortic stenosis. Something that I'd like to bring up is, the awareness of severe aortic stenosis not necessarily being a homogeneous group. In fact, it's probably a heterogeneous group, and some people have proposed new classifications based on flow and gradient, particularly with stroke volume. And they've also included measurement of BNP in those determinations. There's quite a lot of conflicting data out there regarding the relevance of this and actually the prognosis of low flow gradients. So I think at this stage it's just a question of being aware and watching the space. But really, if you're faced with a patient with severe aortic stenosis, how do you approach it? Well, if they have an ejection fraction less than 50% or they're undergoing other cardiac surgery, well, they require a valve replacement, and that's a class 1 indication. If they develop symptoms on an exercise stress test, they aren't actually asymptomatic. And you'll find that many people deny symptoms, and it's useful to subtly to bring it out. Look for high-risk features, an aortic valve area less than 0.6, an elevated mean gradient, a very high velocity, or a blood pressure drop and ventricular arrhythmias are all indications to consider AVR. But more importantly, it's to reduce your surveillance interval, and I think that's important. If you've got somebody with severe aortic stenosis, I tend not to follow them every 12 months. I follow them every 6 months if I think they're in a high-risk category, and I think that's the relevance. So the risk of sudden cardiac death is actually low. It's 1% per year, and the risk of aortic valve replacement, as I mentioned, is 3%. And we've talked about, I think that the principal aim is identifying people who likely will progress and watching them closely. The next part of my talk, I'm going to go on about transcatheter aortic valve implantation, and I'm going to talk about two valves in particular, the Medtronic core valve and the Edwards sapien valve, for the reasons that they're both approved for use. There are a variety of other experimental valves, all of which are having good results, but I'll just concentrate on this for the purpose of the presentation. And as opposed to asymptomatic patients, if you look at symptomatic patients, it's a whole different story, isn't it? So if you don't intervene on severe aortic stenosis, there's a dismal prognosis. And that is the reason that we watch these patients so closely. And I guess the issue is now, what is the role for transcatheter aortic valve implantation? Where does it lie in these patients? So if you look at the next slide, it looks based from North America, the classification of people into low risk, intermediate risk, high risk, and extreme operative risk, based on the SDS score, which is the Surgical Thoracic Society score. And this places people based on the risk of mortality for cardiac surgery, and it identifies them as being candidates or not for aortic valve implantation, in particular transcatheter valves. The present data suggests quite simply, if you have severe symptomatic aortic stenosis and you have extreme operative risk, TAVI is the first option. If you have a high operative risk, TAVI should enter the discussion, and there's data that I'll show you to suggest that it may be a preferred option. In the intermediate and the low operative risk, we're waiting for further information. We do have some trials that are suggestive and thought-provoking, but there's nothing definitive as yet. So if you look at the actual data for transcatheter aortic valves, the partner trial was the seminal trial that got all of this started. It used the Edwards sapien balloon expandable valve, and it was used in patients who were extremely high risk, and it paved the way for this technology to be used and for new valves to be used as well. And the study design was essentially to look at inoperable patients by virtue of their gross comorbidity and randomize them to either transcatheter aortic valves or medical therapy or standard therapy. And that meant you could have a balloon valvuloplasty or possibly just medical therapy. And it randomized those patients. Now, there was a second arm of the trial that looked at high risk, but I want to concentrate on the inoperable because this is where the money is when it comes to actually approving this device. The next slide shows patient characteristics, and they're terrible. You know, the patients are over 80, the SDS scores are high, they've got chronic pulmonary disease, they're oxygen dependent, they've got frailty, and these are patients that we really would be looking from the end of the bed and asking the question, should we be doing anything at all? And that'll become apparent soon. But if you stack that up against putting in a transcatheter aortic valve and doing nothing, well, it proves the point that there's a dismal prognosis with aortic stenosis, and these patients did well. There was a significant reduction in mortality, which is now out to 5 years in these patients, and this is with all-cause mortality, and it's replicated with cardiovascular mortality as well. An interesting aspect that came out of this trial is what were the causes of death, and you saw that in many patients in the valve group, there was a high non-cardiovascular risk of death. And they broke that down a little further, and they stratified mortality based on your STS score. And they looked at those who are relatively lower risk, intermediate risk, and high risk. And it became apparent that patients with a lower STS risk score did better if they had a heart valve, and that was essentially because they didn't die of anything else. You know, and so this introduced a concept of futility, there's a high risk, there's an extreme risk, and then there's a futile category of patients who shouldn't have therapy. And it was a really important understanding to come to, because when you look at these transcatheter aortic valves, all experienced interventional cardiologists with appropriate training will be able to implant these valves. But results actually come from patient selection, and that's what we find now. It's all about patient selection. There was another device that was a newer, more slimline device, which was a smaller size and was a self-expanding valve called a Medtronic core valve. And that they ran a pivotal trial that looked at high-risk patients as well. And they used a performance indicator. They didn't want to randomize patients to medical therapy after the obvious benefit of transcatheter valves. And they showed a significant reduction in mortality. And interestingly, they also showed a significant reduction in stroke. And that doesn't reflect that this valve is necessarily better. It means it's a more evolved valve. So the Edwards valve that was used initially was 24 French in size. It was huge. And of course, it's going to cause vascular complications and stroke. And now we're looking at from 24 being down to 14 French. And this core valve French size was 18 French. So the size is coming down. These devices are becoming more rationalized and streamlined. One of the issues that came out of it is we thought it was fantastic. So stroke was low, mortality was low in these patients, and this was really looking very bright and on the horizon. But there was a lot of paravalvular aortic regurgitation with some of these valves, and this became an issue. And it really can be explained by putting a circular valve into an oval aortic valve annulus, and you get paravalvular leak because with heavy calcification, it may not conform appropriately. And that was a lesson to be learnt, and what became apparent is that if there was significant aortic regurgitation, those patients did worse. And people developing these devices immediately turned their attention to aortic regurgitation as a significant risk, and to their credit have developed these devices in a way that really negates that aspect. Moving to the high-risk population, and what we see is with evolving technology, we start in an area where there's no recourse to surgery, and we prove proof of concept, and then once we have determined that it's safe and effective, we can bring down the risk, we can ratchet down the risk, and we can improve its applicability to the general surgical population. So the trial that I'll just briefly mention on here is the pivotal trial, and this was in the high-risk population group, and again it showed a very significant reduction in mortality and stroke. And this was a very important finding, because when I treat patients with aortic stenosis and they're elderly, you'd be interested that some of them don't mind the risk of dying during a procedure, but nobody wants the risk of stroke during a procedure. No one wants to be a burden to their family and be incapacitated, and it's a really important concept. And the reduction in stroke, I think, is a very big plus to show that, again, surgery is a very important thing to do. We talked about a patient selection, and it's really a very important aspect to this. And this slide will basically show that our understanding of risk assessment has changed so much now that we're doing transcatheter aortic valves. Traditional surgical risk scores didn't actually evaluate for aortic valve. That is, the Euro score and the SDS score didn't actually do that. There was a lot that we missed out on and that we're now acknowledging. And I mentioned becoming a geriatric cardiologist. To my dismay, but I am, and I know about frailty, because the frailty index is an important component to identifying risk. Major organ compromise is an important component, as is specific issues like a porcelain aorta or a hostile mediastinum or severe kyphoscoliosis are all risk factors that are not traditionally incorporated into many of the risk factor scores that we see, but we recognize are very important. So we just talked about the assessment of frailty, and I put that slide up so everyone could share my pain. That's what we need to look through when they walk into my office. An aspect that we know about implementing this new technology is that it honestly became a little bit of a turf war between the cardiologists and the surgeons. There was no doubt about it, because this was their one domain. I don't see David Taggart in the audience, unfortunately, but I'll catch him later. But really, there was a lot of debate about who should be doing it and how it should be done, and the consensus really is it should be done together. And centres that thrive and have good results work together in a multidisciplinary heart team. And there's no doubt that interventional cardiologists do the majority of implanting via the transfemoral route, but there are other access sites as well, including the transaortic as well. But we know that discussing patients carefully after a full assessment of all of their comorbidity by intensive care doctors, geriatricians, nurse coordinators, nurses, social workers, general practitioners contribute immensely to the outcomes, because we can identify people who are high risk but survivors, and that's a really important concept. And so the patient evaluation at a heart valve clinic is something that we employ in Newcastle in our TAVI centre, and we admit patients who, by virtue of their frailty and age, can't necessarily travel, and we evaluate them over a short period of time and then come to a consensus. So where to with TAVI from here? We've talked about high risk and severe surgical risk, but what else is on the horizon? And there's a lot out there. There are a variety of randomized, well-constructed trials that are in progress looking at intermediate risk, and there are a couple out there looking at low-risk patients as well. And that data is out there, and I think David Taggart today made an important point about the data being out there, but we need to look for longevity in the data as well before we apply technology like this to lower risk populations. So from my perspective, there are a couple of things that are my issues with TAVI. And first of all, from a procedural perspective, I worry about paravalvular regurgitation. That pacemaker rate is higher in some of the valves, vascular complications, stroke, and the actual ability of them to withstand and stand up to surgical valves out to 5 years. But from a healthcare perspective and a health economic perspective, we have to talk about the cost. I mean, these valves cost between $25,000 to $30,000. And we need to look at resource allocation appropriately in our communities about what is the best allocation for those resources. We need to be really careful about our patient selection. And when we implement new technology, we have to do it with considerable oversight by colleges. And as I said, we need a lot more data before we can move it to other risk groups. So, in conclusion, TAVI is indicated for severe aortic stenosis with extreme surgical risk, and certainly high surgical risk if you consider a surgical valve replacement as well. You really require careful screening in a multidisciplinary team to get optimal outcomes. And further data is awaited for other risk categories. Thank you very much.